My name is Smriti. I'm the Director of Programs in Pallium India, and I am delighted to welcome you all to our second day in this series, which is on symptom control and management. We have with us today, leading this session, two very senior palliative care experts in our country who have been an integral part of the original group that developed the resource toolkit based on which we now run these ECHO programs. So I'm very, very pleased to introduce you to Dr. Shoba Nair, who is currently with the Professor of Palliative Medicine at Amrita Institute of Medical Sciences in Cochin, and has formerly held several positions, like she's been a consultant at the Sheffield Teaching Hospital in the UK. She's been a research mentor for undergraduate research methodology programs at St. John's in Bangalore, and also been a former member of the specialty board for MD Palliative Medicine at the Medical Council of India, and an editor with the Indian Journal of Palliative Care. So, and far more credentials than that. And joining her in facilitation is Dr. Rajeshri, who is an MD in anesthesiology and has a fellowship in palliative medicine, but one of the senior trainers in our country for palliative care. And she's been with the Institute of Palliative Care in Thrissur. She's been an associate professor at the Amrita Institute of Medical Sciences, and is also visiting faculty with us at Pallium India. So, leaving the session in extremely good hands, I'm now pleased to pass the baton on to Dr. Raji to do a quick recap of yesterday's session and then move into the main session today. Thank you. Dr. Raji, you're on mute.
Yeah. Am I audible?
Absolutely clear. Yes.
Okay, fine. So, good afternoon, friends. It's very glad to see you again on this platform. So, we have this is the second day of the our PalliCovid ECHO series. So, yesterday we have met and seen how palliative care is relevant in the context of COVID-19. Because most of us, even I too, before learning palliative care principles, thought that palliative care is mainly concerned with people mainly concerned people with advanced diseases and people who are close to end of life. It is not so. Yesterday we were very well emphasized that how palliative care becomes important or relevant in the context of the pandemic, because it affects whole human domain. Like, it's not only physical. Most of us talk about the pulmonary pathology and the modes of ventilation, the thrombolytic therapy in COVID-19. Developing vaccine against it. So everything is okay. But what about the psychosocial and the spiritual domain? People are suffering, and not only the patients, their family members too. So with that introduction, she moved into ethical principles, triaging, and goals of care. We learned that we have autonomy, beneficence, maleficence, and distributive justice are the four major pillars of ethical principles. And we have also seen that they will not be culturally based, but definitely it has got a cultural, and contextual orientation. Ethical principles are not laws, but definitely they give us the legal and moral support when we apply them, and they help us a lot in decision making. But nothing is hard and fast, true or false, and it can be quite challenging in certain situations where the decision making is absolutely challenging and confusing. And it is a very fine balance, and we have to think from the side of the patient as well as their family members. That is the most important. And then the importance of triaging, because all patients with with symptoms of COVID-19 may not be a fit candidate for aggressive measures like invasive ventilation. So we have to identify those patients who will really be benefited with ventilation and other types of aggressive measures, so that the constrained resource can be fully allocated to them. On the other hand, the people who are not likely to benefit, they also deserve equally good care, but not on aggressive mode, but definitely with soothing or comforting measures. That is the importance of triaging. So that is why we have to make that ethical decision making while doing the triaging. And when we do so, we have to get convinced very well, ourselves, and also we have to make others, our team members in the professional team and also the patients and family members. Why are we doing and what are we doing? Finally, what are we aiming at? So we have gone through these aspects like, goals of care discussion. She had very well emphasized or highlighted how goals of care algorithm can be divided into people who are likely to benefit and not likely to benefit. So we have now Ramesh with us with lots of comorbidities, who are an elderly person, but age is not a criteria while deciding for active measures for COVID-19. But definitely people with older age and with lots of comorbidities which are inherent to aging population definitely pose a threat, or challenge for management of COVID-19. So we have a 75-year-old with comorbidities. He had suffered stroke and then hemiplegia. He needs lots of physical support for moving around in home. And now we have his family together with one of his sons returned from Middle East. They are on home quarantine, and this is a very sensitive area. We are standing. We have an elderly person with comorbidities. We have a person who is returned from Middle East on home quarantine, and he is getting comments and inputs from neighbors that you are being an older person, you are likely to get the infection. So he's quite confused. It is not a pandemic now; it is an infodemic when media pour us on lots of information. So we are standing there with Ramesh with lot of confusion and uncertainties. So today we have to see Ramesh again because Ramesh is going to be with us all these 5 days. So today, Shoba is going to highlight, suppose if Ramesh, what if Ramesh is tested positive? What are the concerns? So how we go about managing symptoms from a palliative care perspective, not from an aggressive point of view, from a palliative care perspective. So Shobha is, as Smriti has cited already, she's a very well experienced person in palliative care, working in institutions where teaching is also a major component and teaching is her passion. So over to you, Shobha, and let us have a very good academic list. And moving before handing over the mic to, baton to Shoba, I will encourage all of you to put your suggestions and opinions in the chat box. We will toss in between and we will just take on the chats and discuss. That is how we learn, unlearn, and relearn. Thank you. Thank you very much. Let us listen to Shoba. Over to you.
Thank you, Raji, for the recap, and thank you, Smriti, for the introduction. Good afternoon, everyone. Am I clear?
Yes, you are.
Yes, thank you. So, as you all know, we are going to talk about some symptom management today. And this particular slide has been put together by Dr. Sunita Daniel, another senior palliative care consultant in our country. And myself and Sunita has done this together. So let's move on to our presentation today. So every class that we have, we always have a goal. And if we actually fit our goals into the session, and if we keep that in mind, and I think we're going to get the output and then the outcome later. So if we can focus on what we're going to learn today, that will be helpful for all of us. So what we're going to do is to be able to understand and use management algorithms for common physical symptoms in the context of COVID-19, and to familiarize with a list of essential medications for palliative care. This is adapted from IAHPZ and WHO. IAHPZ is International Association for Hospice and Palliative Care. So what do you think are the main symptoms that any COVID-19 patient can have? Can you all put in the chat box, please?
Okay, we are getting feedback from the group, like anosmia, dyspnea, fever, cough, excellent
Right.
fever, headache,
Right.
myalgia,
Yeah.
dry cough, breathlessness.
Good. Okay.
Very good.
Right. Okay. So we've got certain symptoms. So I think it's impossible to cover every symptom in a session like this where we are constrained for time. So we're going to focus on a couple of important symptoms and maybe one another symptom as we go along. So the learning objectives is to assess and rate the severity of breathlessness in COVID-19, identify agitation with and without delirium. I think this is very important, because the treatment varies. Identify the agitation, identifying with and without delirium. Just focus on that. We'll come to that in the next 10 minutes. Okay. And management of both symptoms, familiarizing with the use of algorithms of both symptoms. I'm sure like you would have received the ebook and you must have gone through it at least very briefly. So you can see that there are different tables and algorithms there which will help you to sort of manage these symptoms and discuss other effective management techniques. And you can see that this ebook can also be downloaded from this particular link that is given on the slide. And also you can download a PalliCare app in which you need to focus on the spelling of PalliCare, K, not C, okay, to support symptom control in palliative care for general settings, which we normally use in our country. So having said that, let's move on. So yesterday's story, I think Moira had talked to you about Ramesh and Ramesh's son Suresh, and what are the dilemmas that they will face, and how can we triage a patient and things like that, and so on and so forth. So today, Suresh, Ramesh's son, calls the COVID-19 helpline and says his father has symptoms of sore throat and dry cough. And at the advice of the medical officer, they decide to move him to the nearest COVID treatment center. So a testing is done, and then he's found to be positive for COVID-19. And Ramesh is clearly, that is, the patient is clearly anxious and unsettled. He keeps asking to see his family. Will I ever see them again? So this gentleman who has symptoms is brought to the hospital and is isolated, tested positive basically, and isolated. And there are issues that he has. So what are the issues concerning him and his family? Could you list that down, please, in the chat box? And how will you respond to them? So if you can list the concerns and how you're going to respond to them together, that will be helpful. Any responses, Raji? Family meeting, fear of society's stigma. Okay. Anyone else? Responsibility towards his family, yes. Is my audio poor? Somebody saying my audio is poor?
No, your audio is quite clear, Shoba.
All right, okay. Financial worries, financial issues. Dr. Shiv Kumar is saying audio is poor to everyone. So is it my audio or Raji's audio?
No, your audio is quite clear.
Yeah, okay.
I request Mr. Shivkumar to please check from his side.
Fear of severe symptoms, yes. So he's saying mine. So anxiety of the patient and his family. Okay, there are a lot of things coming up. Sorry, we've gone back. Right. So, what are the issues concerning him and his family, and how will you respond to them? Is what we asked, and you've said that, okay, of course, that he's worried, he's anxious, and maybe we can have a family conference, a family get together. Now, the thing that we'll shift our focus a bit here just going to a bit of communication here, which will be taken in the next coming days, is that the person who's actually looking after this patient, Ramesh, might not be able to actually have a detailed conversation with the family. So in the triad system itself, if you can appoint someone to have the clinical data at his fingertips and then have a conversation with his family, that will be helpful. So that's a different thing altogether. Here we are focusing on symptom management. So definitely family conference is very good. So those are the concerns. And on day 2 of his admission, his condition worsens with high fever, dry cough, difficulty in breathing. He also reports feeling very tired and unwell. Vitals, heart rate 120, temperature so-and-so, saturation is only 88%. Okay, so the clinical team agree that a transfer to a critical care facility is not recommended and want to focus on excellent symptom control. So the medical officer is worried how they're going to inform him and his family. And the son has been calling and saying, please do everything for my father. Do everything that is possible to save his life. How will you handle this situation? What are you going to do? So yesterday during Moira's session, I think we had gone through the yellow-red pathway. And if you can remember, you'll have a fair idea as to how we can handle the situation. Anything in the chat box?
Not yet. Not yet.
Okay.
Probably the participants were typing. So you just think of, as Shoba has mentioned, ethical principles and goals of care and how to triage, Ramesh. At the same time, son has made a plea, do everything best for my father.
Okay.
Okay, so I need to talk to family regarding goal setting and goals of care.
Okay.
Pedro.
That's a fair answer.
Okay. So I need to do proper communication, citing out his comorbidities and then treatment options available, and then which will be useful or fruitful to him.
Yeah. Okay, so we've got a fair idea as to, what is a pathway that we're going to use. Okay, let's move on. So before moving on, I think yesterday it was said that, I think it was discussed briefly probably that, COVID and diagnosing COVID is a kind of an emergency situation, you could say. If somebody's unwell and they bring him to the ER, somebody who's breathless, or somebody with fever and breathlessness, who's coming in pretty new to the hospital setup, hospital facility. We don't know this patient at all. We as palliative care physicians normally know our patients for months together, or maybe 1 or 2 years. But this is, an unknown patient, and it's an ultra emergency situation. We really do not have time to have a rapport with this patient. But there are ways and means by which you can always behave in a compassionate way, which will be taken in the communication session. So it is an ultra emergency situation. No relationship between the patient and the family. No typical palliation timing for sharing and planning the treatment path. This usually happens in any palliative care setup. Where are we heading and where are we going? So what can be done as a long-term care plan or a short-term care plan, etc., etc. So deaths are linked to traumatic psychological experience for the family and members of the treating team. Even the treating team. Right now, we have a small baby who's just 1.5 years old. Who's, of course, she doesn't have COVID, but she's got a brain tumor and she's actively dying. And she's, throwing seizures continuously. So she's in status epilepticus. We are just back after sort of calming her down. So the trauma that we go through as we see such young patients in our care setup is, I can't explain that. I'm sure, all of you have experienced that kind of a thing. And of course, this patient is known to us for a couple of months only now. She's a 1.5-year-old child. But this is someone, like, for example, we are talking about Ramesh here. Nobody knows him, and this is not a long-term disease that the patient has had. So there is a way of communicating with people that you know and people that you do not know, and how can we kind of hone our skills and improve our skills is what we need to look at to reduce the trauma of the psychological experience. So coming back to the symptoms in patients with COVID-19, the common symptoms that you can see: fever, dyspnea, altered sense of taste, myalgia, fatigue, anorexia, chest tightness. It goes on, so on and so forth. Okay. Uncommon symptoms: gastrointestinal, dizziness, headache, neurological symptoms. You can have even rashes, cutaneous symptoms, rhinorrhea, chest pain, conjunctivitis, hemoptysis, etc. So here's a very useful a diagram which explains the pathophysiology and staging of the disease. I'm sure, like some of you would have seen this. This is a staging proposal, which came in the Journal of Heart and Lung Transplantation, obviously this year, 2 to 3 months ago, which depicts stage 1, stage 2, and stage 3 of the infection. So stage 1, everybody is normal. The clinical presentation, there's nothing in the clinical presentation. It is called the viral response phase. And the clinical symptoms are mild constitutional symptoms, maybe fever, just more than 99.6, or dry cough, diarrhea, headache, which you can kind of brush aside and say, oh, this is one of those days kind of thing. And then comes, stage 2, where in pulmonary phase, you have 2A and 2B phases in the time course that develops. There's shortness of breath, hypoxia, and the investigation wise, in stage 1, you can see lymphopenia, increased prothrombin time, etc. In stage 2, you have abnormal chest imaging, transaminitis, low normal procalcitonin. Remember, procalcitonin is a sign of sepsis, inflammation, infection. You have that raised in bacterial infection, but in viral infection, that can be low. So low normal procalcitonin can be a diagnostic feature of a viral infection. Stage 3 is hyperinflammation. And you have host inflammatory response phase in stage 3, where you have ARDS, shock, cardiac failure. Elevated inflammatory markers: CRP, LDH, IL-6, D-dimer, ferritin, troponin, natriuretic peptide, etc. Okay. Now, there's a lot of controversy regarding the treatment per se of COVID, which is not the focus of this the 1 hour talk that we are having today. But still, I think we need to talk about the different medications that can be used, which is, one is remdesivir, which cuts the recovery times, but no evidence on survival, basically. So, sometimes in cancer patients, we prescribe tyrosine kinase inhibitors. That means the oncologists prescribe tyrosine kinase inhibitors, and the patients come and ask us, should we take this medication? Is there any advantage that if we take this medication? But a lot of studies have shown that, even though it cannot prolong the life per se, it can reduce the suffering that the patients might have. So the quality of life of patients improve with tyrosine kinase inhibitors. Similarly, remdesivir cuts the recovery times, and the quality of life improves in these patients, is what they have found. But there's no evidence on survival. If the symptoms are really severe, the patients succumb to the disease. Another drug that is found favoritism now is dexamethasone, 6 milligram. They found that in UK, they found that it reduced deaths by 1/3 in ventilated patients and 1/5 in other patients receiving oxygen only. Now, about hydroxychloroquine and chloroquine, there's a lot of politics associated with it, whether to give it or not. And in US, there's chloroquine and even steroids. They give it only for clinical trials. Whereas in UK, dexamethasone is being given. In India, hydroxychloroquine is being given, as in many other countries. So you concentrate on interleukin-6 inhibitors, interleukin-2 inhibitors, and the works. So there are different drugs that can do that, like steroids, like they say colchicine is helpful, azithromycin is helpful, etc., etc. Okay. Now let's come back to our topic today. So, how do patients present? They are least serious, or they have URTI, or they have flu-like symptoms, or the infection is very severe, and they become severely ill and they need ICU admission. Okay, so 80% of our patients have mild illness, 14% severe illness, and 5% critical illness. So again, continuing with our patient Ramesh, so everyone is in agreement that Ramesh should have conservative treatment based on comorbidities and previous performance status. I think Moira had said yesterday that Ramesh had ischemic heart disease and diabetes, if I'm not wrong. But his performance status was okay. That means he was not bedridden or needing help to do his own chores and things like that. So his performance status was decent. And the son has said, please make sure that he does not suffer. So you want to make sure that Ramesh has best symptom control. And you have started on high flow oxygen. Okay. And the chest X-ray of Mr. Ramesh shows lung infiltrates, has raised D-dimer, leukopenia, raised transaminases. And you're discussing with your senior colleagues. So, suppose you are the junior doctor in the setup, or middle senior level doctor, and you want to ask questions to your senior. What questions are you going to ask? And what are the key issues in control of the symptom of breathlessness? What is the question that you're going to ask your senior? Can you put it in the chat box, please? Anything coming up, Raji?
No, not yet. So now we are, moving to symptom control. So if we have to provide good symptom control for Ramesh, so what are the points which you would like to discuss? Yeah, use morphine. Sandeep prefers to use morphine.
Okay. So he's going to ask his senior whether someone can use morphine. Excellent.
Okay. Remdesivir early use.
Yeah. Okay. Any key issues in controlling the symptom?
Steroids. There is
Steroids,
another response.
So remdesivir and steroids, we just now said, and someone said morphine.
Low molecular weight heparin.
Okay.
Are we going to use the medications on clinical trial at this stage? That's another pertinent question.
Another question that people have asked, yes.
Okay.
So,
oxygenation and antibiotics if necessary. Steroid, high flow oxygen, antibiotics. Teach non-pharmacological techniques like breathing techniques, relaxation techniques. Very good. Very good. Ventilator
that's excellent,
management. Yeah. Okay.
Right, okay. So then we've got a few answers. Let's look at, before answering all these questions, let's look at the holistic picture of breathlessness. As we all know, breathlessness has a complex pathophysiology, and in COVID-19, it's even more complex. It's like you have the thromboembolic episodes, you have endothelium getting affected of pulmonary vasculature, throwing microemboli, and you have infiltrates, you have cytokine storms happening, and you have alveoli reacting, the surface of the alveoli reacting, and you have infiltrates into the alveoli, and you have ground glass opacities, and so on and so forth. So it's a very complex pathophysiology that happens in COVID. Okay, that is one aspect. There is vulnerability. Okay, I'm so sorry. Age and comorbidities which affects vulnerable people. Anxiety, inflammation, loading, no definite treatment, and isolation. So there is a lot of information floating around in WhatsApp groups, in other groups, and in the internet. The people are like really worried which is to be followed or not. A lot of people take it upon themselves to direct others without any sound information, what is available in the groups, and these people come in contact with them, and they get worried. This is what is going to happen to me too, that sort of thing. And they all know that there's no definite treatment, and there's anxiety because these patients are isolated and with themselves and not able to speak to their family members. Of course, they can speak to them over the phone. Psychosocial issues can play a role because they might feel guilty, or I should have just not ventured out. I should have worn my mask even more strictly or in a rigorous manner. And they feel angry with themselves or with others. And sometimes they become fearful. And of course, financial aspects, like someone said earlier, all this play a part in increasing the anxiety and increasing breathlessness. So breathlessness cannot be looked at only as a physical symptom, but we also need to look at the psychosocial and spiritual aspects. Okay. Now, it's very easy to say that follow the COVID-19 management protocol. I'm sure your hospitals, wherever you're working, will have a COVID-19 management protocol. What we're discussing here is above and along with these management to help patients to control their symptoms. Okay, so our government, India government, has a protocol which every hospital in the country is supposed to follow, and every state has actually come out with their own protocols as well, taking inspiration from the central government's directives. The Ministry of Family Welfare and Health and Family Welfare has given directives in our country. So similarly, people from other countries will also have their own directives, and you can compare and contrast if you want and see what works and what doesn't. So correct the correctable factors, treat bronchospasm if present. Now, when we are looking at COVID-19 and breathlessness because of that, we should not forget the other causes for breathlessness. The patients might be asthmatic, they might have COPD, they have a lung cancer. These kind of things should not be forgotten. So treat bronchospasm if present. And in spite of all the treatment, if refractory breathlessness happens, that means that it is not improving despite optimal medical management. Then what do we do is a question.
Meanwhile, Shoba, sorry.
Yeah.
Meanwhile, there are responses like giving bronchodilators and seeing whether the patient is, not patient, Jamish is sleeping well or comfortably, and asking whether he is anxious or restless, and whether we can use benzodiazepine. These are the other chats which
excellent. Okay. Yeah, for breathlessness, whether we can use benzodiazepines. Yes, I'll come to that in a minute.
Yeah, please.
That's a very good point. Yeah. Okay. So, like someone said, definitely non-pharmacological measures is the key for any management. Whatever we say in palliative care, we always have non-pharmacological measures first. Positioning helps. In COVID-19, please remember that when the patients become breathless, the most comfortable position that people say is prone position rather than supine position. So patients might feel difficult to lie on their backs. So you can try maybe sideways, or even helping them to face with their face down, etc. Okay, relaxation techniques, breathing techniques, cooling the face, etc. might help, as we all know. Now, when you come to mild to moderate breathlessness, morphine, midazolam, and lorazepam might be helpful. So morphine, 2.5 to 5 milligram per oral every 4 hours. Okay, 1 to 2 milligrams subcutaneously. Anybody has an objection in using morphine in breathlessness? Please put it in the chat box. So since it is put on the slide doesn't mean that you have to agree with it. Please let us.
So, Kemal, Visin Show has suggested that regarding cooling the face in our practice, it's not advisable to use a fan.
Yeah, that's right.
It is true. It's true. Because why is it not advisable? And prone position is better. Drowsiness, Uma has commented. Drowsiness regarding what? While using morphine? Sandeep Kumar has come forward with a suggestion that safe and wonderful drug. Okay. Uma, okay. Morphine. Morphine produces drowsiness.
Yes, that's right.
Okay. It can depress respiratory and cardiac centers. Revati.
Hmm?
Okay, okay. I mean, using fan is not advisable because Visinchu has commented again, since the virus is considered to be, it's not airborne. I mean, maybe using fan, you might be spreading the aerosols or the droplets. That might be the reason. And again, I think key is the amount of dosage. Must be with respect to morphine dose. Okay, yes. Morphine produces drowsiness, but it is a toxic symptom, I mean, toxic sign of morphine. I mean, morphine. It is not a side effect. So, I mean, we are using morphine because of many other reasons. Morphine is useful in relieving restlessness without producing respiratory depression. And then it is there 8 hours, and yes, you may spread the droplets. Okay.
So is this a responses that you're reading, Raji? Yes, I got a gist of it. Okay. So morphine in opioid naive patients, that means people who have never used opioids before, or when they got admitted with you, they are not on opioids. Morphine is started as, we normally started as 2.5 milligram, a small dose, maybe 3 times a day to begin with, and then see like how the patient fares, and then probably increase the dose 2.5 to 5 milligrams orally every 4 hours, or 1 to 2 milligrams subcutaneously. Now, midazolam, somebody was talking about benzodiazepine. Definitely, you know, anxiety contributes towards breathlessness. So midazolam definitely has a role. It's the shortest acting benzodiazepine that is available. It just works for 2 hours. So 2 to 5 milligram, we have written 4th hourly, but still, if the patient is really breathless, you can start a continuous infusion or give even more frequently, like every 2 hours, or slow IV or subcutaneous infusion can be started. Now, what we found is, lorazepam is very, very helpful because it is a tablet which can be taken quickly and kept under the tongue. We don't have a specific sublingual preparation, but we use oral preparation in our country as sublingual tablets, and we found it extremely useful. We recently had a patient who has got interstitial lung disease. The patient is from Mali, Maldives, because our government and Maldivian government has an arrangement for healthcare, and they do come to a hospital, Amrita, at Kochi. And this gentleman couldn't sit, couldn't sleep, couldn't lie down flat because of breathlessness. And he was put on short dose of morphine. He had a long-acting benzodiazepine, which is clonazepam at night, but we ended up giving him with, putting him on lorazepam, 0.5 milligram sublingual, and he was like, up and about. So it really works. So lorazepam was very, very helpful for this patient. It similarly can be helpful with COVID-19 patients as well who are very anxious. So continuous infusion of morphine and midazolam can be tried over 24 hours. You don't have to actually worry about the doses because you cannot by heart the doses. Please do look up the PalliCovid ebook or your country's the drug manuals like SIMS or BNF or anything of that sort to guide you as to what the dose should be, or discuss with your seniors and do safe practice. Even when we've been practicing palliative care for so many years, but every day we do look up. This morning we looked up, doses of phenobarbital for the child who was continuously throwing seizures. So we have to be extremely careful when you write doses. So please don't hesitate to look up your drug manuals to decide on the dose. So here's the algorithm, which is given on page 14. And you can see the patient in ICU and the patient in the ward. There's a slight difference between the two, wherein the doses, here it is IV and subcutaneous, here it can be oral and subcutaneous. Midazolam is added. As I said, please don't concentrate on the dose right now. We can always go back and read. And what we need to remember is morphine 5 milligram subcutaneous, 2.5 milligram IV, or fentanyl 500 microgram, and midazolam 5 milligram subcutaneous, 2.5 milligram IV can be given, every 15 to 30 minutes until symptomatic improvement. The patient has come to you, is in severe distress. We can stand there and give SOS doses till they are comfortable, and then put them on a continuous infusion, which we generally do in our practice. Now, the conversion dose of morphine to the oral, from the oral to subcutaneous and IV, in our country, we normally take it as like if the patient is on, suppose a patient who comes to you is a cancer patient who is on a particular dose of morphine, say 60 milligrams, and the patient has become so breathless, and we want to slightly increase the dose of morphine. He's not able to swallow things orally, then you have to calculate the dose accordingly. So an arbitrary conversion rate that we take is for oral converting to subcutaneous, we would divide the oral dose by 3, and to subcutaneous we divide the dose by 2, and to IV we would divide the dose by 3. Now in other countries like UK, the subcutaneous and IV dose are similar. For example, the oral dose is divided by 2, it is given as intravenous, and again the same thing is given as subcutaneous. So here we divide it into half and give subcutaneously, divided by 3 we give intravenous to be on the safer side. We can always give SOS doses and hike up the dose in the next 24 hours. So Ramesh's condition has been stable for a day, but the staff noticed that he's becoming agitated. So he was breathless, and we say, for example, he's in the ward, we started him on oral morphine. He became all right for some time. And then the staff notices that, he's becoming agitated, mumbling incoherently and trying to remove his mask. So the nurse looking after him feels he's frightened. What do you feel is the cause of his symptoms? And how will you assess and manage his new problem? Please put it in the chat box.
Okay. Hypoxic delirium.
Yeah.
So meanwhile, waiting for more responses, people have commented positively and negatively about morphine.
Mm-hmm.
And then I have made some clarifications in the chat box, and I have said that morphine is now widely recommended by pulmonologists as well because of its unique qualities in relieving respiratory distress by reducing the respiratory rate, and then by improving the produces pulmonary vasodilation, and then better ventilation perfusion match.
Excellent. Yeah.
And then by reducing the sense and work of breathing, it might delay type 2 respiratory failure as well. Okay, we will come to the chats as well. So there are suggestions of going for doing ABG and looking for oxygen saturation, and then whether this present scenario is because of hypoxemia or electrolyte imbalance, and could be from sepsis as well, as Manu has commented. And Sandeep has said, that to use haloperidol.
Yeah, so he said he's thinking of delirium.
Yeah.
Yeah, all right. So there's a lot of, possible and plausible causes. So we've been on a journey with this patient, Mr. Ramesh. So his son calls us up and asks, okay, he's got the symptom, do we come in? So they came in, he was tested positive. And then we focused on what are the symptoms that he can have and the psychological issues that he might have, which will be dealt in the next coming days. We are focusing mainly on symptoms here, and we found that, okay, he can have breathlessness and maybe agitation, which is a main concerning symptom. So right now we finished breathlessness, and now we're dealing with agitation, delirium. So people have said, yes, it could be delirium. And what is the cause of delirium is what we want to know. So we always need to remember that if there is a correctable cause, we need to sort of rectify that. Now, this WhatsApp chat has been put in here by Dr. Sunita because she found it very important. This has been doing the rounds in the Western world. People are talking to each other, doctors are talking to each other and saying that, it's horrendous. The agitation, the amount of agitation people have is like unbearable, and it's extremely difficult to control. And people are not having any success with it. So they've tried high doses of haloperidol and things like that. And sometimes the only option is to sedate them. So intractable symptoms, sedation, end of life care, which will come later. So delirium is a very difficult symptom to handle. Meanwhile, we should not forget that Ramesh is a little, on the senior ladder, and this chart might be helpful later on. You can have a look at it. COVID-19 in the older adult, wherein they might present differently. They might not present with cough and breathing difficulty. They might present with delirium, like they do with urinary tract infections. People don't straight away present with, especially in the elderly group, with anything to do with urinary symptoms. They might just present with diarrhea, which could be a UTI symptom. So we have to look at different things like clues in the biomarkers, which might be slightly different, and the management of these symptoms in elderly might be different as well. So you can have a look at this chart a little later. Just a mention about red map framework, which will be useful. Can we talk about your care when you're ready? This, if we have time and the people are oriented, this can happen. If we don't have time, this is not going to happen. Okay, so what do you know and want to ask? Okay, you've got this infection, this is what you have, your test is positive. If you're having any symptoms, or if cannot be controlled in the ward, what is it that you would like us to do? So what do you expect? So what we know and we do not know, we can always discuss with them. What matters to you most is very important for them. Probably, they would say, okay, I do not want to go on a ventilator, or come what may, I want to go on a ventilator. So it's very important to record that. And what is the action that we are going to do? So this can help and this will not help. And here, I think, looking at the narratives from all around the world, and if we decide, okay, this patient is not going on the ventilator, there have been incidences where people have been on the ventilator for months together, 60 days, 90 days, and they've come out of the ventilator. But what is the damage that is caused to their lungs is not known. So what is the rehab potential for these patients? Are they, able to walk, move around without oxygen, things like that? The data is coming later. So what is the action that we're going to do, and what is the plan? Okay, let's make a long-term care plan or a short-term care plan for this particular patient. And remember, our plans might change, so you have to be flexible. So just a quick takeaway from this chart is red map framework. We can read up more about that. Okay, now how do we assess delirium? And when a patient is agitated, it's extremely difficult to be sure that the patient is oriented, or whether the patient is not oriented is extremely difficult. So what do we do? Now this tool, we found it useful. It's normally used for patients who are 65 years and over. It's called the 4A test, delirium assessment tool. What are the 4 A's? One is alertness. Yeah, the second one is AMT4, which is the abbreviated mental test 4. And the third one is attention. And the fourth one is acute change of fluctuating course. So alertness, all of us know. There are, scores at the end of it. So you can always have a look later. AMT4 is an abbreviated mental test 4, in which you ask 4 questions, which is age, date of birth, name of the hospital or the building that they are in. Remember, right now, sometimes the hospital facilities are full. So there might be a banquet hall next door, and you're utilizing that as, as a facility. So hospital or building, which is a current year, those kind of things. That's, people are unlikely to forget the current year though. And attention. I think this is very difficult to ask. You can ask people to name the months, 7 months, backwards, 7 months or more correctly. The score is 0, but it's very difficult in this situation. I personally feel to ask, check for attention. Then acute change of fluctuating course. If there is a difference, you have to speak to the family members. You might be able to speak to them only over the phone and say, is there a change in his behavior, which can be taken, if it is yes, it can be taken as delirium positive. So then you go the delirium pathway, or otherwise observe. Okay. Now, anxiety, agitation, delirium, we should not forget this whole thing. Again, breathlessness contribute towards this, which needs to be managed. Urinary retention or constipation can cause delirium. Pain can cause delirium, we should not forget that. And withdrawal syndrome in people who comes in suddenly, they might be on drugs, and they come in suddenly, and they are deprived of that. Alcohol and drug users, or tobacco, even simple tobacco, cigarette smoking. So they go into withdrawal, and anxiety and agitation could be because of that. So could we have a nicotine patch, nicotine gum, if they're oriented, or if they are kind of drowsy, sleepy, maybe a nicotine patch or agitated nicotine patch would be helpful if they can't take anything orally. So no, common things first, common things should not be forgotten. So we need to look at the whole spectrum. Any interesting thoughts, Raji, or should we stop and discuss about that, or just continue?
Yeah, I mean, there was a suggestion from the group that whether we can use ketamine for producing symptom relief, probably for breathlessness, and then because it can produce sedation and bronchodilation. Then I responded in the chat box that sedation produced by ketamine may not be that soothing for the patient right now, and it can produce lots of hallucination as well. And then bronchodilation, which might be produced from ketamine, may not be that significant in COVID pathology. Yeah. So, because it produces hallucination, I don't think it's a first-line drug which may be considered in symptom.
Absolutely. I agree with you, Raji. So ketamine probably is not a right medication at the moment, but if people are on ketamine, some of our patients are on ketamine. In the sense, we give them as a short course to take them away from a particular opioid, and as a part of opioid rotation or intractable pain and things like that. We do use ketamine in our setup, but probably not in COVID-19 patients at the moment. So here's the last slide, which is the flow chart. Sorry, Raji. Anything?
No. I was just saying, okay.
Yeah. Okay. So agitation, I think this is a very important algorithm, which is there in the page on page 17 of the e-COVID book. Agitated and disoriented, which is delirium, and agitated and oriented, which is anxiety, panic, or fear. Right? So agitated and disoriented, you have haloperidol, 1 milligram slow intravenous subcutaneous or 1.5 milligram per oral. You have mild, moderate. Bolus injection can be given, and a continuous infusion can be started. Doses are given there. Please go back and read. And if it's moderate, along with haloperidol, you can add in a benzodiazepine, which is midazolam, okay, to sedate the patient, which is very helpful. Now, sometimes it's very difficult to differentiate. You've administered your 480 test. Even then, you're a little doubtful whether the patient is just simply anxious or is just overwhelmed with all that is happening around, or really disoriented. Sometimes these patients have lucid intervals. And if the patient is actually disoriented, and if the patient, you're talking to the patient in that lucid interval, it's sometimes difficult to pick up that the patient is disoriented. So in case of doubt, please do not give benzodiazepines. Please go in with an antipsychotic, which is haloperidol. Because in such situations, the administration of benzodiazepine can aggravate agitation. So please bear this in mind. Okay, in case of doubt, you cannot absolutely be clear whether the patient is oriented or not, then go in with an antipsychotic. But if you're clear, and if the patient is agitated and oriented because of anxiety, panic, and fear, and if able to swallow, definitely lorazepam, like I said earlier, did magic to that patient, and clonazepam, which is a long-acting thing, which can be given 0.25 to 0.5. And if not able to swallow, you can definitely go in with midazolam. And if moderate, then you combine anti-anxiety with antipsychotic. So benzodiazepine with an antipsychotic, which is haloperidol. Okay, so intractable severe symptoms, sometimes normally we go up till 10 milligrams of haloperidol, which is usual practice when the patient is actively dying, terminal agitation, we go in with that. But there's been instances where we've used a maximum dose of injection haloperidol. A lot of drugs used in palliative care is, you can say often use or often drug use, which is not indicated, but it can be used in a certain circumstance. So there are a lot of indications and different doses given for different drugs. So definitely it is under the law that we practice. So haloperidol 20 milligrams and injection midazolam 30 milligrams can be given as a continuous infusion, either intravenous or subcutaneous in 24 hours. And remember, these medications are compatible and they can be combined. So midazolam, morphine, haloperidol can be given as a single syringe driver. There's no problem. The drugs do not precipitate. It can be given safely. So we've talked about breathlessness. We've talked about agitation. And I think in the next 2 minutes, we are going to finish this by talking just a wee bit on pain and in the severity of pain. Sometimes we fail to understand that these patients were on pain medications. They come in with, this kind of breathlessness and things like that. And if you don't have the history properly, we're not able to speak to the relatives properly. They might not have the regular drugs with them. They've come off in a hurry. So pain management takes the least priority or the backbench. So just to refresh our memories about WHO analgesic ladder, mild, moderate, and severe. It's a 3-step ladder. The ladder is not shown here, but we can always remember that for mild pain, please do give paracetamol. With moderate, again, you can add in paracetamol to tramadol. And if it is severe, definitely morphine, paracetamol and morphine. We normally do not give a weak opioid like tramadol with a strong opioid like morphine. So we always stick with one particular opioid. We don't combine a weak opioid, and it doesn't make sense, and a strong opioid. Pharmacologically, it doesn't make sense. Okay, you can always have adjuvants depending on the type of pain. Now, what are adjuvants? They can be, anti-neuropathic medications like tricyclic antidepressants, anti-epileptic medications, steroids, etc. Just remember that paracetamol is the safest analgesic that can be given in anyone. So if the patients have pain and fever, so paracetamol is the best drug that you can give. So paracetamol, tramadol, or paracetamol, morphine, or plain simple paracetamol again. Now there's a controversy about NSAIDs. Initially, it was said that NSAIDs is not a good idea. It should not be given to patients and things like that. I think they later on changed and said that, of course, Brufen, etc., can be given. So just check on the latest guidelines about that and then go along with it. Okay, now we've come to the essential medication list, which is taken up again, adapted from IHPs and WHO. There's a whole lot of medications here, which is essential in the situation. So when you have a pandemic and when you have disaster that is happening around, you definitely need pain medications. You definitely need, agitation medications, and you definitely need medications for controlling breathlessness. So all this is listed here. You can have a look later. We're not going to read this whole list. To summarize the whole thing, so we need to recognize that symptom complex of breathlessness and agitation is found in severe COVID-19 pneumonia, definitely there. Opioids should be made available to manage breathlessness and pain. There was a question yesterday, if morphine was not available, what do we do? So of course you can use fentanyl. It is there in the algorithm for breathlessness, very clearly indicated. 480 delirium assessment tool is very quick and you can use it very easily. And you don't need specific training to use that tool. Remember to assess, rule out, and manage other causes of delirium. For anxiety and restlessness without disorientation, start a benzodiazepine. And for restlessness, agitation with disorientation, start an antipsychotic. Now, to just allay the fears about morphine in breathlessness, like Raji has already explained to you, morphine definitely plays a role in breathlessness because it controls the fear, it can reduce the anxiety, it can suppress the respiratory center, and it is a vasodilatory drug which reduces the workload of the heart and the lung to pump against pressure. So it produces vasodilation, produces drainage. It's used in pulmonary edema. So if you along with diuretics, this can be used as a continuous infusion in cardiac coronary care units. So definitely morphine plays a very significant role in controlling breathlessness. So do not be scared. to use morphine. So further resources and training. And this is a list of the faculty members in our team. Thank you for your listening. And if you have more questions, please put in the chat box.
Shoba, there was queries regarding the use of dexmedetomidine and cannabis for, like breathlessness or probably for symptom relief and sedation towards symptom.
So dexmedetomidine and even ketamine and things like that definitely is used in ICU. Somebody is coming from an ICU setup, so who's asked these questions. So they have a role in probably in palliative sedation later on if the symptoms are intractable. So it's very difficult to use these in the wards. So in an ICU setup, definitely yes. But in most of the, for our patients in the wards, we have found that sedation can be done with a good dose of morphine and midazolam in it together. So dexmedetomidine in particular for sedation, we might not reach that stage probably. Anything you want to add, Raji? You're much more experienced with anesthetic medications.
No, nothing like that. I mean, there was a query regarding, like extrapyramidal side effects with haloperidol. So whether that is so common, so I have just responded saying that it might occur, but in the doses which are cited in the presentation, which is it is quite uncommon. I mean, it is not routinely we see that, but it might occur particularly with older patients. So we need to be vigilant. So you have more comments, Shoba?
About?
I mean, extrapyramidal side effects and the
So definitely. So haloperidol and azithromycin and everything else given together, QT prolongation and things like that. People are so worried. But I would say if if you have moderate symptoms and if of course, if you are giving azithromycin and haloperidol together, it's always safe to do an ECG and calculate the QT interval and be sure that you're doing the right thing. But we are not giving methadone and other drugs, which we do have in our country, but every facility in our country do not have methadone. So I don't think we need to worry too much about QT interval. But extrapyramidal side effect, some patients, even with a single dose, can develop extrapyramidal side effect. In such patients, it becomes very difficult. So haloperidol. So if the patients are oriented, you can always give them quetiapine or risperidone, which is an atypical antipsychotic. But when they're on a ventilator, then you'll have to put on an NG feed and things like that. So and if they can't take these injections and things like that, if the QT interval is getting prolonged, then we can use an atypical thing, which can be given via NG tube to these patients. I'm sure like a lot of people can chip in with that. We do use atypical antipsychotics for such patients, yes.
Okay. Any more questions? Or Moira, would you like to comment? And Moira had posted that some queries regarding communication issues and end-of-life care practices may be dealt in another sessions. And we have to go for simple, commonly used drugs which are available in our country and the local setup, because our aim is to provide maximum symptom control with our limited resources. So, I mean, as you said,
thank you, Raji. Thank you so much, and great session from Dr. Shoba and Dr. Raji. I was just sharing the results of a recent audit from the UK showing that nearly all of the time, in fact, every one of the patients in their setting were managed with the simple regimens that Shoba, you've been mentioning in the algorithms. So I think it's very nice to discuss these complex issues, and some of you are in ICU and specialist settings, so it's good to have the chance to discuss them. But also, please be reassured that we are not saying now in the research these very difficult breathlessness and agitation problems. We're seeing people with symptoms as part of a holistic setting, and we're finding that straightforward medications are managing those symptoms along with non-pharmacological interventions and holistic care most of the time. Thank you.
Right. Yeah. So Dr. Sandeep has put in for EPS Benadryl. Yes, definitely. You can immediately stop the drug. That's the first and foremost thing that you do if somebody develops EPS. Withdraw the drug that is causing the side effect, first and foremost step, and then of course give Benadryl. Yes. Yes, you can see Revati Saravanan has said you see extrapiramidal side effects with
Yeah,
metoclopramide.
yeah, that's what.
So MSET, haloperidol, azithromycin, deadly combination. You know, MSET that can prolong QT interval as well, and that can produce EPS as well. So it's a you know we're actually dealing with precarious drugs, I would say, and you need to be extremely careful. Watch your patient carefully, because some people can just develop the side effects quickly, and others don't.
Okay.
So have we answered all the queries and questions, Raji?
Yeah, I think.
All right.
Anyone has more comments or queries? Please come on, chat box.
All right. I think
Okay,
so.
Shoba,
Yeah.
so much thanks to you for the wonderful session. And and thanks the participants to their comments and suggestions in the chat box. And my thanks are due to Moira as well, because she also got, she also put some valuable information on the chat box. So we have discussed today how Ramesh went through his, varying symptoms, starting probably from fever, cough, breathlessness, and then delirium. So we have seen how it can be alleviated with simple and locally available drugs, and what should be our goals of care while we do so. So our aim is not to provide aggressive ICU management, but to provide maximum symptom control if possible in the hospital setting or the first line treatment centers. So non-pharmacological measures are equally important. And so finally, to sum up, it is the patient comfort that is the most important thing. So thanks all of you, Shoba, Moira, and all participants, and thanks to TIPS team as well for hosting. And please come with your, please come well read for tomorrow's session on communications, where you can have a discussion on more challenging issues of communication. So hope meeting you soon in 2-3 more days with different teams and topics. So thank you all. And over to Smriti, please fill up the feedback form so it is valuable for us. Thank you.
Thank you, Dr. Shoba and Dr. Raji, and thank you, Moira, as well, for coming in. Lovely session. I think it was very enriching to all the participants. Great to see all the exchanges in the chat box. And just reiterating what Dr. Rajshri said, please do have a look at the resource toolkit so that you come prepared for tomorrow's session, which is on communications, another extremely essential skill, especially at a difficult time like this. So do fill in the poll before you check out, and we will see you tomorrow. Thank you very much, and have a good afternoon and evening. Thank you.